Good afternoon. My name is Kate Locke, and I'm Assistant Professor of Bariatric and Minimally Invasive General Surgery at the Medical College of Wisconsin in Milwaukee. I'm going to be speaking tonight on the aspiration therapy for the treatment of morbid obesity. I'd like to thank, in particular, our chairs of this sessions, Dr. Bueno and Dr. Sandler, for the invitation to speak on this topic. I have nothing to disclose. So as far as the objectives today, I'm going to be talking about the development and approval of aspiration therapy as a treatment for class 2 and 3 morbid obesity. I'm going to talk about the data supporting its use up to date, as well as some of the controversy surrounding this therapy. I'm also going to ask the question of is this therapy cost effective? So for the treatment of obesity, we know that bariatric surgery is the most effective treatment. However, only about 1% of eligible patients undergo surgical treatment. This treatment gap is attributed to many different causes, including some patients not fitting eligibility guidelines set by insurance companies, and other patients not really interested in the risk or permanent nature of surgery, while others complain of the cost. So new options were developed. Many of them have been shared already in this session, including endobarriers, the endoscopic sleeve gastroplasty, as well as the intragastric balloon systems. And finally, now we're going to talk about aspiration therapy. The endoscopic aspiration therapy was really derived from the technology of the percutaneous endoscopic gastrostomy tube. This kind of technology can be used as an outpatient procedure. It is reversible and it is patient controlled, which led to this development. The technique for placement of the aspiration therapy system includes a fast overnight pre-procedure. Pre-procedure antibiotics are generally given, and it starts with an upper GI endoscopy. The placement is then very similar to placement of a PEG tube using transillumination on the belly wall. About 10 to 14 days after placement, the A tube or aspiration tube is cut about 1 centimeter from the skin and attached to a skin port. Aspiration instructions are then given to patients for aspiration from the tube about 20 minutes after each meal containing greater than 200 kilocalories. When we look specifically at the device components, we see that this aspiration tube is an all silicone tube with holes in the intragastric portion to allow for aspiration of a portion of the ingested meal. It does involve a skin port valve, which has an embedded safety device with a counter. This counter tracks the number of times the connector is attached to the skin port and allows only a maximum of about 5 to 6 weeks of therapy before the patient would need to reestablish with a provider. It also involves a companion device or a siphon, which allows for two-way flow of fluids to permit drainage from the stomach while also infusing water into the stomach, and of course the drainage tube. The pilot study for the aspiration Aspire Assist device was initiated in 2009 as a clinical randomized controlled trial. In this study, 18 patients were included, with 14 completing 1-year follow-up. The patients were randomly assigned to a 2-to-1 to aspiration therapy with lifestyle interventions versus lifestyle interventions alone. Per the study protocol, anyone after 12 months who was able to achieve 25% or more excess weight loss was invited to continue for an additional 12 months of follow-up. As you can see in this flow diagram, 7 of the 11 patients in the aspiration therapy group made it through week 104 of analysis. When we look at the results of this study, we see that the percent weight loss in the aspiration therapy group was greater than the lifestyle treatment group at 52 weeks. When we look at the percent excess weight loss, this was also greater in the aspiration therapy group than the lifestyle treatment alone group at 52 weeks, with a mean of 49% excess weight loss in aspiration therapy versus 14.9% in lifestyle treatment alone. After 52 weeks, in the group that was invited to continue for an additional year, no significant change of weight loss was occurring in these subjects who continued aspiration therapy. But as you can see in these tables, their weight loss was maintained. The authors further followed these patients with psychological assessments. Both pre-procedure and throughout the study period, patients underwent the eating disorder examination, the Beck Depression Inventory, and the Stunkard Eating Inventory. The eating disorder examination is an interview-based assessment of disordered attitudes and behaviors related to eating, body shape, and weight, designed to diagnose eating disorders. The Beck Depression Inventory is a self-administered questionnaire that assesses the existence and severity of symptoms of depression, and the Stunkard Eating Inventory is a self-administered questionnaire that assesses 3 behavioral traits that can affect the control of body weight, including things like cognitive dietary restraint, or the deliberate control of intake, disinhibition, or the loss of control over food intake, and perceived hunger, and awareness or susceptibility to hunger. Through these psychological assessments, the authors aim to identify patients foremost who would not be a candidate for the procedure, and likewise, if the implementation of aspiration therapy could lend towards disordered eating behaviors or depression over time. The authors found no adverse eating behaviors induced after aspiration therapy. BDI scores started low and remained low throughout the study, and subjects in the aspiration therapy group demonstrated improved restraint, less disinhibition, and decreased hunger. The adverse events reported were most commonly due to peristomal pain, nausea, and vomiting. The majority of patients experienced these symptoms in the first 4 weeks after placement, and after 4 weeks, patients described ongoing peristomal pain, which was improved when the aspiration tube design was reworked. One patient did have an episode of hypokalemia on account of noncompliance with the routine supplementation, which was prescribed. All patients, after aspiration therapy is initiated, are maintained on PPI therapy and potassium supplementation post-op, and compliance with this regimen was reinforced in this patient. Based on this pilot study, the authors conclude that aspiration therapy is a safe and efficacious weight loss option when analyzed to 1 year. At 2 years, weight loss was maintained in the aspiration therapy group, and the authors also point out that the degree of weight loss achieved was more so than can be explained by aspiration alone. The authors suggest that activities to make the therapy more successful, such as chewing food well, drinking more water, and limiting in-between snacking, may have made weight loss more successful than would have been accounted for just based on calories removed. Another theoretical concern was that subjects would have increased food intake to compensate for aspirated calories, and this did not prove to be the case. The aspiration therapy weight loss system went on to have a 1-year multi-center randomized controlled trial aptly named the Pivotal Aspiration Therapy with Adjusted Lifestyle Pathway Study. This was initiated in 2012 and results were published in 2017. Patients were randomized 2-to-1 to 52 weeks of treatment with aspiration therapy with lifestyle counseling versus lifestyle counseling alone. The aspiration therapy group was invited to continue an additional 48 months if they lost and maintained 10% of their baseline body weight. 111 patients were included in the treatment group and 60 patients in the control group with 1-year follow-up. Based on the modified intention to treat analysis, patients in the aspiration therapy group achieved a 31.5% excess weight loss compared to 9.5% excess weight loss in the lifestyle treatment alone group. A greater portion of patients in the aspiration therapy group, more so than the lifestyle counseling group, lost at least 25% of their excess weight. This was 58.6% versus 22%. Predictors of success with aspiration therapy included early responsiveness, defined as 5% or more body weight loss at week 14, and this was predictive of weight loss at 52 weeks. Early responders in the aspiration therapy group who completed the study lost 17.2% body weight at 52 weeks, compared to 4.9% body weight lost in those who were not early responders, which is a similar loss to those in the lifestyle counseling alone group. No demographic or baseline characteristics were different between responders and early responders. The adverse event profile in this study was very similar to that seen in the pilot study, with 90% of the adverse events of those known to be associated with PEG tube placement, such as intermittent abdominal discomfort, abdominal pain after placement, nausea and vomiting after placement, and peristomal irritation. 50% of these adverse events occurred within 7 days of placement, One procedure was unable to be performed due to the inability to transilluminate on the body wall. There were 3 serious adverse events described as 2 instances of peritonitis after placement, requiring admission for pain control, and 1 prepyloric ulcer, which was thought to be secondary to device migration. The authors conclude that treatment with aspiration therapy in class 2 and 3 obesity was more successful at achieving weight loss than lifestyle counseling alone. The procedure may be performed safely as an outpatient and is reversible. The authors suggest its use to bridge a therapy gap between lifestyle modifications and more traditional bariatric procedures. This study really paved the way for the FDA approval of the device in June of 2016. The indications put forth by the FDA include patients at least 22 years of age and a BMI between 35 and 55 kilograms per meter squared. The device is intended for long-term weight loss that is greater than 6 months. As the device gained traction around the globe, a multi-center post-market observational study was undertaken in 5 European cities. The results of a 201 patient registry was published in 2016. These authors had an expanded use of a BMI of 35 to 70. However, other inclusion and exclusion criteria appeared similar in nature to the Pathway trial. At 1-year follow-up, a mean excess weight loss of 43% was demonstrated in the 155 patients who were included in that analysis. And over the preceding several years, although there was significant loss to follow-up, patients continued to have significant excess weight loss that was maintained. At year 1, 46.3% excess weight loss, on down to 48.2, 50.3, and 47.9%. There was significant loss to follow-up, as I mentioned, with only 82, 24, and 12 patients having long-term follow-up at each mark of 2 years, 3 years, and 4 years. In this small cohort of patients, the weight lost in that first year was maintained through year 4. It should be noted that this study also did look at a variety of cardiometabolic parameters, and they found significant improvements in all parameters aside from lipid analysis, including an improvement in A1C, fasting glucose, blood pressure, and triglycerides. An additional outcome tracked by the European observational study was the reason for discontinuation. In this study, 199 patients successfully underwent gastrostomy tube placement. 47 patients discontinued treatment and had the tube removed. Looking at weight loss achieved by this group, we see that 1/3 had weight loss less than their peers with the therapy. 2/3 of those who discontinued their therapy had the same or more weight loss than their peers. The reasons for stopping treatment are listed here, most commonly achieving their goal weight. Some had inability or unwillingness to adhere to therapy, and others were pursuing bariatric procedures. Lastly, I wanted to mention an observational study out of Sweden in 2012. This is a small study with only 25 patients included from a single center. They were followed after aspiration therapy treatment was initiated. By the end of their first year, 20 patients were included and 15 patients were followed to complete a second year. At 1-year follow-up, a mean excess weight loss of 54% was achieved, and at 2-year follow-up, a 61% excess weight loss was achieved with no significant adverse events reported. These graphs demonstrate the weight loss, the body mass index, and the excess weight loss tracked over time in the study. Note that the weight loss, BMI, and excess weight loss declines up to 1 year and then stabilizes up to 2 years. The last thing I wanted to mention was this study by Schweda et al. From the American Journal of Gastroenterology in 2018. These authors looked into comparing aspiration therapy to sleeve gastrectomy or Roux-en-Y gastric bypass versus no treatment, and used a Markov model to estimate the cost and quality adjusted life years. The conclusions from this study is that aspiration therapy may cost less in the short term. However, in the long term, it cost more than bariatric surgical procedures and generated fewer quality of life years compared with bariatric surgery. The authors attribute this to high maintenance costs for the technology and a high discontinuation rate. They also attribute it as being lower level of effectiveness, secondary to lower weight loss achieved compared to bariatric procedures, and this high continuation rate with subsequent weight regain. So in summary, we have data regarding aspiration therapy for treatment of class 2 and 3 obesity in a limited number of patients out to 4 years. The randomized controlled trial by Thompson et al. Describes 31% excess weight loss with aspiration therapy combined with lifestyle counseling, compared to 9.8% excess weight loss in lifestyle counseling alone. Nystrom et al. Followed these patients for 4 years and found 46% excess weight loss at 1 year, with maintenance of this weight loss out to 4 years. The discontinuation of therapy was not insignificant, with almost 50% of patients discontinuing therapy at 4 years. The adverse events from this technology are few, and most are treated non-surgically with only rare hospitalizations. So the proponents of this technology may conclude from it that you can achieve a significant weight loss with this therapy, that the therapy is reversible, it's under patient control, and it is safe. Dissenters of this therapy, however, will comment that there are concerns regarding long-term use, there's potential for misuse, and there's weight regain after discontinuation, and some may speak to the cost associated with it in the long term. I think there's potential areas of use for this as a bridging therapy between lifestyle counseling and bariatric surgery, but the utility of this therapy within our armamentarium of weight loss options is really unknown at this time, but it will certainly become a topic of study and debate. I want to thank again our chairs of this session for inviting me to speak. I will take any questions via email. Thank you for listening.